Hello, I'm Jenny Barnett from Cambridge in the UK, and I've come here to Paris to talk about using cognitive tests as biomarkers in neuropsychiatric disorders. I'm a psychologist originally. I have a position as an honorary researcher at the University of Cambridge, and I also work for a company called Cambridge Cognition, which makes the Cantab computerized neuropsychological tests. Hello everyone. I feel I should apologise for not speaking in French, but if I spoke in French you wouldn't understand me, so I'll speak in English. But please stop me if I'm speaking too quickly or if there are some words that are difficult. We'll get through this. Okay, so as I think Professor Leboyer said, I'm a researcher at the Department of Psychiatry in the University of Cambridge, and that's one hat that I wear, and then the other hat that I wear is that I'm a scientist at Cambridge Cognition, which is a company, a spin-out company from the university which makes computerized cognitive tests. So I'm going to talk to you today about cognitive biomarkers, some of the work from the university and some from work within the company. So in case there are people in the room who are not so familiar with cognition, you can think about it in many different ways, but this is one way that I find useful, that I've stolen from Trevor Robbins. So this talks about cognition as being the cumulative effects of some inputs, things like attention, how awake you are, how alert you are, what you perceive. At the level of representation, how you represent things in your memory and store those things and act on them. And then at the level of executive function, how you use your cognitive control to make decisions, make plans, how you are flexible in your cognitive control. And of course in our clinical lives we sometimes see each of these things going wrong as a symptom. So we see people who have poor impulse control or poor memory or something like that. But what I'm going to try and talk to you today about is the idea that we can think of each of these things and measure them very specifically, very reliably, and that could be a biomarker that would be useful in the same way as some of the other biomarkers that you will have heard about in this lecture series. So let's think about what cognitive biomarkers do, and what I really mean here is if we have a good cognitive test and we use it as a biomarker, what might that help? Well, of course, we know that the clinical labels that we attach to people, DSM or ICD labels, are not very good. They don't really describe very well what is out there in the real world biologically. So cognitive biomarkers, like other biomarkers, might help us to specify more accurately what is really going on, what a particular group of people are like. And that might be helpful for research and also in clinical practice, also in developing new drugs and that kind of thing. From a patient's point of view, cognitive biomarkers might help you to diagnose more accurately or treat more carefully, or to give them some better prediction of what the course of their disease or what the outcome of their disease might be. And I've put these together and sort of said better phenotypes, so a better way of describing the phenotype. We also might think of biomarkers to detect patients earlier, so to find, in the same way that we use things like blood pressure, high blood pressure, or high cholesterol, to find people who are at risk. They don't yet have a problem, but they're at high risk of a problem. To detect early when they do start having a problem, and to treat as quickly as possible. And we might think of using cognitive tests in that way. And finally, in monitoring change, it can be difficult to understand if someone is really getting better or worse, if a treatment is really having an effect or not, just by asking them questions. So it's useful to have an objective way of measuring change. And I think that cognitive tests can do that. So they can help us to detect whether change that we see is normal or abnormal, whether a treatment is working or not, whether you're getting some side effects or not. And this might have effects such as making it easier to monitor compliance in patients, encouraging them to stay on their drugs. And also in research, we use cognitive tests a lot in my Cambridge Cognition role as endpoints in clinical trials, so to see whether a drug is helping a particular aspect of cognition or not. So I'm going to start with Alzheimer's disease, and I know that's not an area that many people here work in necessarily, but it's one where biomarkers and cognitive biomarkers are quite well advanced, so I think we can use that to think about how our fields might go in. So I'm going to make you do a cognitive test now. It's the first cognitive test of the afternoon, so I hope everyone had a good lunch. And this is a test of memory. It's a test of episodic memory, and what you have to do is you have to watch this screen, and some patterns will appear in the white boxes, and your job is to remember which pattern is in which box. Okay? So here we go. So to make this more difficult, I'm going to talk over the top to confuse you. So this is a test that we use in the early detection of Alzheimer's disease. One of the reasons that we think it's particularly sensitive to Alzheimer's disease is because this form of memory, associating an object with a location, is something that your hippocampus is good at, and your hippocampus is where the first cells die in Alzheimer's disease. There we go, I hope I distracted you. So now you saw a pattern in each box, and your job is to say which box you saw this pattern in. Okay, everybody agrees. And this one? Okay. Ah, this looks like you were all awake. And last one? Very good, very good. Okay. So this test is called the Paired Associates Learning Test. So you're learning an association between a pattern and a location. And those of you that have children and play the game where you turn cards over will know that young children are very good at this test, and it becomes much more difficult as you get older. And as I say, it's particularly useful in the early signs of Alzheimer's disease. So to what extent is this really a biomarker? Well, let's think about some of the criteria that people use for biomarkers. So it needs to be something that you can measure objectively and reliably. It needs to be something that reflects a pathological disease process. So there's some kind of biological relationship between the disease and the biomarker, and somehow knowing about this helps you to predict how a patient is doing or how a patient will do. So just to give you some example data, this is what happens if you do neuroimaging with this task. You get some nice activation bilaterally in the hippocampus. So we think that there is some kind of relationship between this test and the disease that we're interested in, which is Alzheimer's disease here. There's also some kind of correlation. These are data between showing the number of errors you make on that test and how much beta amyloid you have in your CSF, which is a marker, of course, for Alzheimer's process. We know that how well you do on this test, how many errors you make at intake, and also how much worse you get over time, is quite predictive of whether you will have a stable course or whether you're deteriorating into a neurodegenerative process rapidly. We know that when you treat patients with Alzheimer's drugs, they do better on this test. And these are data, this is a correlation between how well you do on this test and how often you have memory failures in everyday life, where you forget where you put your keys or forget what you went out to do. So there's some correlation between how well you do on this biomarker and something in the real world. So hopefully you can see that this is, has got potential as a biomarker. It's not perfect, but it meets some of the criteria. And as I said before, biomarkers in Alzheimer's disease are quite well advanced. So this is a graph, a fictional graph that I've made up, that shows the relationship on the x-axis as you get worse. So these are people here everybody has the disease. At this stage, you don't yet have symptoms. You get some symptoms and have mild cognitive impairment. You get mild Alzheimer's disease, moderate Alzheimer's disease. So people are getting worse as they go along this axis. And this is, for any biomarker, you can imagine people move between normal and abnormal. And there are a range of biomarkers that are used commonly in Alzheimer's disease, things like the amount of amyloid that's in your CSF, or the amount of tau that's in your CSF, or some neuroimaging markers. And these are sort of traditional things that we think of as biomarkers. And then there are some other things that I'm suggesting you might use, more clinical things like performance on the CANTAB PAL. And the details of this don't really matter, but the idea is this, that if you know how a person scores on multiple biomarkers, then that allows you to put them along the x-axis. You know how severe their disease is. So, so if a person has mild cognitive impairment, then we would expect that they would show up as positive on amyloid, FDG, PET and tau, and on the paired associates learning test, but they would not yet have some other, they would be negative on some other markers. So the idea here is that you can use multiple biomarkers to help you understand whether someone has a disease and how far along the disease is. And of course, clinically, the decision you're making all the time is, does this person have a problem and do I need to do something about it? And so we can also think of biomarkers as being these different levels of investigation that you might need to use. So in Alzheimer's, the first thing you might do is check someone's memory. So you're thinking to yourself, oh, is there a problem here? If they do badly, you need to know, is that a new problem or have they always had a poor memory? So you would ask what we call an informant, so maybe their family member or friend, something like that. Is this a new problem that you've noticed? Then the next thing you want to know is what disease is it that's likely to be causing this problem. So you might do a more full cognitive exam. Does it fit an Alzheimer's pattern rather than a different form of cognitive problem? You might want to do some things to exclude other diseases. So you do an MRI scan to exclude that this was due to a stroke or due to a tumour. And then finally, if you want to know is this definitely an Alzheimer's pathology, then you can do some of these new biomarkers such as an amyloid scan. And the reason I have this as filters is because doing some of these things is very easy and very quick and very cheap, like checking someone's memory. And doing other things at the bottom of the filter is very expensive, very difficult. You can't always get hold of them in routine clinical practice. So we need to put biomarkers in an order that makes sense, in order that we best use the resources so that people who really need these investigations get them. The people who don't need these investigations, you can rule them out as early as possible. So we have done this recently in Cambridge Cognition. We've been trying to take this cognitive test that's been around for a long time and make it useful to primary care doctors, so everyday general practitioners in the health service in the UK. So we took the test, put it on iPad, because the test is touchscreen, so now that iPads are available, it's much more usable for people. We made it much simpler to use so that everything is automated, the instructions speak themselves, it speaks many languages, unlike me, and just generally so that it's very simple to use for a clinician who is not an expert in cognitive function. And so now the primary care doctors in the UK can use that to decide when someone comes in who is worried about their memory. The doctor has to decide, do I reassure this person and send them home, say everything's okay? Do I send them through for further investigations to a specialist clinic where they will have to wait for some time, where there are expensive investigations? So this gives a sort of answer for a primary care doctor. Or actually it gives a three-level answer. It says, okay, you take this test and either you are normal for someone who is your age, sex and education, you are in a borderline range where we think the doctor should monitor you again in 6 months or 1 year, or you're in a range where you have a score that makes you think you probably have something clinically wrong with your memory and you should be investigated. And so the idea is the primary care doctor has a patient that comes in who's worried, they can give them this test and they can get out a clinical decision whether they should investigate more or not. So this is an example of where we're trying to take a cognitive test that has been something that neuropsychologists and specialists do, and we make it easy enough and useful enough that even a primary care doctor can use it in the same way that they would order a blood test or measure your blood pressure or something like that. So that's the primary care version that I just showed you. So the idea of making a cognitive biomarker like a blood test as a filter, so making cognitive biomarkers useful to keep people in and out of other investigations. And we also use this test to monitor change over time, so to look at whether people are starting to perform really poorly and should have investigation, or if they're having some intervention, whether that intervention is helping, whether the drug is improving their memory or not. So that was all a detour into Alzheimer's disease. What about schizophrenia, which I'm sure many people in the room know a lot more about? Well, when we think about cognition in schizophrenia, of course, we know that cognition is really impaired in schizophrenia. Lots of patients have very big cognitive problems, and that some of those problems tend to be related to the symptoms that they're experiencing at the time, and some of those problems seem to always be there. So there are state and trait elements. Of course, cognition is hugely researched in schizophrenia. Lots and lots of research goes on. And so what I thought I would talk to you about this afternoon is whether any of these cognitive tests that I'm saying might be biomarkers can be useful clinically or in your research, maybe to help subtype patients or to predict something useful for patients. So let's see how we do. So here's the problem. Whatever cognitive test you give a group of patients with schizophrenia, they will do poorly on, normally around 1 standard deviation below the mean, something like that. So here's data from a meta-analysis. This is in chronic patients with schizophrenia. But in first episode patients who have had less treatment, less time in hospitals and so forth, we still see very similar results. So this is one of the very early studies, but I don't think the data have changed very much. We know that even first episode patients have a lot of cognitive deficits. And if we go earlier still, we know that some of those cognitive deficits are there right from as early as we can measure at the start of life. So this is a meta-analysis that we put out a couple of years ago, where we looked at the data from birth cohort studies. So people that have been followed from life and then, people that have been followed from birth, some of whom will develop schizophrenia by chance. And what you see is that when you measure cognitive function in childhood in those people, they are about a half a standard deviation poorer than the rest of their peers. And that's true if you measure them in their school age years, so age 8, something like that, or later on, so in late teenage years or as young adults. So we see this cognitive deficit right from the start. And we see it also in people who don't have the full clinical syndrome of schizophrenia, but who do have some psychotic-like experiences or psychotic symptoms, but not enough that we classify them as having schizophrenia. So these are data from the 1946 birth cohort in the UK, where people were tested on measures of cognitive function 3 times in childhood, at ages 8, which is blue, 11, which is red, and 15, which is green on these graphs. And on the left-hand side, psychotic-like experiences at age 53. So this is when they were 53 years old. We asked them some very simple questions about whether they'd ever had any funny experiences. And lots of people say yes. About 22% say they've had one or other of these psychotic-like symptoms at some point. And we find that those people who say yes have a small but significantly worse cognitive function than the rest of the people. And on the right-hand side, we're moving a bit further down the psychotic spectrum. So these are people who, at age 36, we asked them those kinds of questions, and then if they said yes, the nurse followed up with them to see, was this really a psychotic-like symptom? Was it clinically relevant? So these are people that said they had clinically relevant psychotic symptoms, but not schizophrenia, not any other diagnosed disorder. At age 36, about 5% of people in the general population said yes, and again you can see that they have a significantly worse childhood cognitive function, despite not going on to have, a diagnosis of schizophrenia. And this is at age 53 again. This is how many psychotic symptoms they said they had experience, so we asked them about 4 things. So they could have a number between 0 and 4 that they endorsed. And you can see that people that say they've had all 4 of these things tend to have a much lower childhood cognitive function, but there's some idea that there might be a dose effect across the spectrum. So what we have here is something where this is a very non-specific marker. General cognitive function, these are from IQ-like tests in childhood. But it seems to be a marker of that brain process that, when it goes very strongly awry, causes schizophrenia, but that in these people who don't have a clinically diagnosed disorder still seem to have some predisposition for it. So cognition seems to be a marker of that predisposition of how you will, of the experiences you will have many years later in life. So the other problem in schizophrenia is that individual patients' cognitive function is very heterogeneous. So we hope that there would be a pattern across different cognitive tests that told us something about the causes of their disorder, perhaps. But that doesn't seem to be the case. So these are some data, looks like a biomarker panel actually, but these are cognitive tests. So each one of these lines is a different cognitive test, and each one of these columns is a different person. So these are the first 70 patients that I saw when I was a PhD student in a first episode psychosis clinic in Cambridge. So, and you can see that each person's performance on each test is colour-coded red, orange, green. So where you see a red square, that means that that patient performed badly on that particular test. And really why I'm showing you this is just to point out that there's no obvious pattern, right? Patients have a very heterogeneous presentation with respect to their cognitive function. And that's bad news if we're looking for cognitive biomarkers of schizophrenia or cognitive predictors, or if we're thinking about what we could put out in the population that would help us to detect people at risk for schizophrenia. But if I had to put my money on one thing, on one cognitive test, then this is where I would put my money. So this is the Cantab spatial working memory test. Don't worry, I'm not going to test you guys on this one, but I'll tell you how it works. So as you can see, there are some boxes on the screen, and you have to search through these boxes by pressing on them until you find one of these tokens. And when you find this token, you save it in your box over here. And then the important instruction is that if you find a token in that box, you should never go back to that box. So the token will never be in the same box twice. So it's a working memory test because you're having to constantly update where you have found tokens as you move through looking for other things. And there are lots of, one of the useful things about this test is that there have been lots of animal equivalent tests. In fact, the Cantab human tests were made to be similar to animal tests so that we can do research across rodents and monkeys and humans, which is very useful for drug development and that kind of thing. So these are just some examples of the kind of tests that we do in mice, like the radial arm maze, and in monkeys, like the spatial delayed response task. And in fact, there is a monkey Cantab, which you can see looks pretty similar. So from these data, we have a pretty good understanding of the neural and the neurochemical bases of this test. So patients with schizophrenia do really badly at this test. This is first episode schizophrenia, with patients making a large number of errors, particularly at the most difficult stages. So at the most difficult stage, there are 8 boxes to search through, and you can see patients with schizophrenia, with first episode schizophrenia, make about double the number of errors that controlled age-matched controls make. In fact, patients with schizophrenia do even worse than patients with large frontal lobe lesions, who, as you would expect, do pretty badly. So again, at the 8-box stage, the most difficult stage, matched controls make some number of errors, patients with frontal lobe lesions make more, patients with schizophrenia make even more. So this is really a test that patients with schizophrenia are very, very bad at. And one reason for that is that we think it's a pretty good biomarker of dorsolateral prefrontal function. So here are some imaging data from the test. And we also know from some studies that were carried out a long time ago in Cambridge, where I was not involved, where the researchers in the Cognition and Brain Sciences unit in the Department of Psychology and the Department of Psychiatry in Cambridge used this test in patients with different circumscribed lesions in the brain. So patients with orbital frontal lesions actually do pretty well at this test. They're quite similar to controls, maybe even a bit better. Patients with dorsal-medial lesions don't do too badly, but patients with dorsolateral lesions or large frontal lesions that include the dorsolateral prefrontal cortex do really badly at this test. And of course, that fits with what we know about schizophrenia. We know that, we've known for 20 years or so, that hypofrontality is seems to be one of the crucial things about schizophrenia, about cognitive function. So these are data from a meta-analysis looking at lots of studies of executive function in schizophrenia. And what you see is that patients with schizophrenia, they activate the same network as controls, but they don't activate it enough. So you see lots of areas where controls are activating a lot more than patients with schizophrenia in the dorsolateral prefrontal cortex and also in the anterior cingulate. And so we think that this is one of the reasons that this test is so very sensitive in schizophrenia and why it might be a good biomarker. I think the other reason that it might be sensitive is about the development of different types of cognitive function in life. So most cognitive functions develop early in life. We already talked about how that paired associates learning test is fully developed by the time you're 6 or 7 years old. You're really good at doing that. But spatial working memory is not, because your prefrontal cortex is still developing through late adolescence, maybe even into your 20s, something like that. So this is the normative data from that Cantab spatial working memory test that shows the number of errors you make at different ages. So this is 4 and 5-year-olds. You can see they're pretty bad. They get better down to 16, 23-year-olds. They're the best people. They make the least number of errors. And then as you get older, you start to make more errors again. And of course, the thing that's important is that schizophrenia, the acute stage of schizophrenia, tends to strike here, right? It tends to strike when your dorsolateral prefrontal cortex should be in its peak of function. So I think that's another reason why this cognitive test and tests that tap this dorsolateral prefrontal function may be particularly good biomarkers of cognition in schizophrenia, because they're the last bits of cognition that haven't yet developed by the time this awful catastrophic neurochemical cascade or whatever schizophrenia is happens. Now, I haven't talked very much about the effects of drugs, although I spent a lot of my working life thinking about that. We know, of course, that blocking dopamine, which we do in patients with schizophrenia and bipolar and other things, is not very good for specific cognitive functions. Here's what happens if you give haloperidol to controls on that task. So this is just a single acute dose of haloperidol. This is their baseline performance, and after 3 hours, they make a lot more errors on that task. So, of course, blocking dopamine isn't good for your cognitive function in tasks that depend on these prefrontal regions. But we can also use this test to look at what does improve cognitive function. And these are results from some small-scale studies in Cambridge using a single dose of modafinil, which is this wake-promoting drug that was used originally for sleep disorders and is sometimes used in things like ADHD. So this is just a single dose of modafinil versus placebo on a digit span, forwards or backwards. Modafinil makes you a little bit better. This is in chronic schizophrenia patients. This is digit span backwards and the spatial working memory task error score in patients with first episode psychosis. So in both cases, just a single dose of this compound seems to be having a significant effect on this kind of task, which is very good news for patients, of course. But we're interested also in non-pharmaceutical outcomes and in using cognitive tests as a measure of efficacy of those. And this is just an example of the very many interesting studies that are going on, looking at cognitive remediation and cognitive training in a number of ways. So these are data from an American group who have been doing a very specific auditory training procedure. And they do this for more than 50 hours in every patient. And what you see is that patients' scores on all sorts of domains of cognition improve once they've had this very heavy amount of training. And mostly it seems to stay stable. Even once the training has stopped, it stays stable for follow-up. And just playing computer games, sadly, doesn't have that effect. So it does seem like this quite specific form of training is having a good effect. And I think that this is really hopeful for all of our research and also for clinical practice. The idea that we might be able to use cognitive training and cognitive tests in a way that will improve the lives of patients. Okay, I'm going to talk very quickly now about ADHD. This is a possible biomarker for ADHD. I'm not sure if it's there yet, but here's one idea. This is a test where you have to respond to this arrow by pressing on the screen. So the arrow points left, you would press this button here. And so you're pressing away, going left, right, left, right, left, right. So I can't coordinate that. And then every so often, about 25% of the time, you'll hear a beep. So the arrow appears, you hear a beep, you have to inhibit your response. So this is a measure of impulse control. Can you stop this response that you have already started to make? And the test is automated, so it gets easier and harder, so that 50% of the time you'll be able to stop it, 50% it won't, so it adapts to your behaviour. And the outcome measure that we're interested in is what is the time between the go signal, the arrow, and the stop signal, the beep, at which you can get it right 50% of the time. Okay? So I don't have audio on this, so you have to imagine. So left, you press left, right, you press right, left, you press left. You can press left, but there was a beep, so you don't, okay? So this perhaps doesn't give the best impression of it without the beep, but you can imagine that because you're used to doing this action left, right, it's difficult to inhibit. So patients with ADHD are pretty impaired at this test. Here's the length of time that they have to act to make that inhibition when they're unmedicated, and when they're medicated they look more like controls. And that's the case for adult ADHD and for child ADHD. And this is really the basis of why we treat patients with methylphenidate. It does seem to help this impulsive kind of behaviour, and we can measure these real-life behaviours using this impulse-based lab task. It also seems to have quite a specific neural basis. So there have been studies looking at patients with brain lesions. So this is a correlation between the amount of damage that you have in your inferior frontal gyrus and the stop signal reaction time, this outcome measure. And you can see there's a pretty close correlation between how damaged your inferior frontal gyrus is and how much slower you are to respond. And that's not the case for other areas of the brain, superior frontal gyrus and so forth. This was data published by Adam Aaron. And you can also mimic this in healthy controls using TMS, so transcranial magnetic stimulation. And you see that when you use TMS on the inferior frontal gyrus in either the left or the right hand, when you're responding with either your left or your right hand, this time slows right down again. So it seems like this cognitive biomarker has quite a specific neural basis, which gives us hope, which is useful. And again, it can be remediated using this drug modafinil that I spoke about earlier, and also with some other things, methylphenidate, which we already treat patients with, atomoxetine, which some people treat patients with. So it seems to be something where adequate treatment produces a clear response on this marker. And that could be useful, for example, in convincing patients that they should keep taking these drugs. If you're able to show in an office-based test or a lab-based test, you can show someone's performance improving, that can help encourage them to to stick with medication when they may not want to take drugs for a long time, for example. Finally, I want to think about what other disorders cognitive biomarkers might be useful for. So we've largely been talking about conditions that are characterised by cognitive impairment, dementia, ADHD, that sort of thing. Schizophrenia and bipolar disorder and autism fall more into this category, where cognition isn't the only thing that's the problem, but the condition is characterised to a large extent, where cognition is an important symptom of the condition, and it's something that helping cognition would really help the patient. And then there's an even larger range of things where cognitive biomarkers might be useful because it might be useful to have an objective measure of something that otherwise you're relying on a patient to self-report, or something that changes very slowly, where cognitive function might change much quicker, reflecting the change in brain activity that's happening. So this might be things like eating disorders and PTSD and so forth. So I'm going to show you one last cognitive test. This is quite different from the others. So the ones I've showed you so far, they're quite effortful. They're depending on quite a high level cognitive function. This is a much more basic process. So what happens in this test is you see a face on the screen very quickly, and you have to judge which emotion that face is expressing. Are they happy, sad, angry, fearful, disgusted, or surprised? Those are your 6 choices, right? And sometimes they appear so quickly that you can't really tell. You have to make a guess. Sometimes they appear slowly enough that it will be obvious to you which one it is. So there are many social cognition tests where you see a face and you make that same judgment about emotion. And of course you can train people to be better at making the judgment using cognitive processes. So thinking about, can I see their eyes? Can I see their teeth? Is their smile pointing up or pointing down, or that sort of thing? This is an attempt to make that much more basic, so you just see a flash of a face and you have to go with your gut instinct sort of thing. So it's a much more subconscious version. But I apologise that I can't demonstrate that to you. Okay, so hopefully I've convinced you that cognitive biomarkers may be real biomarkers, and may be useful to the extent that they are reliably usable and measurable, that they can be related to disease processes and pathologies, sometimes to a trait-like disease process, some underlying pathology that has always been there, sometimes to a state process that can be improved using a drug, for example, or another intervention. And of course, if that's the case, then they can be related to clinical benefits. I think the thing that's important is that there are all these things that we call cognitive tests, and that in thinking about the use in research or in clinic, we need to think about something that's very specific. So that's useful in a specific disorder or related to a specific symptom or a specific neural system. And hopefully if that's the case, and hopefully I've given you some examples here where I think it could be the case, then we can use cognitive tests as biomarkers in research, particularly in drug development, where we're looking for quicker changes than, or smaller changes than we can reliably observe from the outside or from asking patients. And if we can make these things work in research, then hopefully we can make them work in clinical practice, and that means that we can take all of this research that's done into cognitive function and actually make it work in a way that can change an individual patient's treatment or prognosis. So I apologise, I have to run off to catch a train pretty quickly after the end of this talk. But if any of you are interested in any of the things that I've said, then this is my email address, and I would be really delighted to hear from you. I'd like to thank Professor Leboyer and the Foundation for inviting me here. It's been really interesting to see everything that you guys are up to. And particularly I'd thank my colleagues, Peace Jones, who's the head of psychiatry in Cambridge, who's been a great mentor, and Andy Blackwell, who runs Cambridge Cognition. And thanks to you all for coming.